My task would be today to talk a little bit about EUS drainage procedures. There are not many talks purely focused on nowadays what I consider a hot topic on interventional therapeutic EUS, but I will try at least to cover part of those new exciting topics. Interventional EUS has been around for a while. However, mostly it was case reports, not huge amount of patients have been performed, with the exception of peripancreatic fluid collection treatment, as well as plexus blockages or neurolysis. The major developments happened in the last 10 years, or particularly in the last 6 years, with more and more introduction of specialized tools dedicated for interventional EUS. When we are talking about different drainage procedures that have been introduced and sometimes also reinvented previously known procedures with the use of special stents, special access devices, and special tools to get the access. I will focus only on some of those topics which are provided on the slide. But if anyone has more questions, maybe after the lecture, due to the limited time, I can even answer questions about, for example, gastrojejunostomy, which is beyond the scope of this lecture, as we have one of the largest collections of almost 150 patients with this procedure. There is also later today another lecture dedicated to pancreatitis, and I assume it will also cover endoscopic treatment of peripancreatic fluid collection. So I will just only briefly highlight few things, which still may be sometimes controversial, sometimes not supported by sufficient data. But we know that EUS-guided drainage slowly and increasingly takes over as an alternative to surgical and percutaneous approaches, particularly in all these cases of PPFC. Percutaneous drainage has a similar technical success rate in symptomatic pancreatic pseudocyst. And percutaneous approach is, on the contrast, associated with a higher reintervention rate, longer hospital stay, and increased number of imaging studies. Thus, endoscopy should be clearly preferred over percutaneous approach. Similarly, another study of Shyam shows that there is similar technical and clinical success, but the cost and length of hospital stay is in favor of endoscopy in comparison to percutaneous approach and surgery. Another important study aiming about this shows that major complications, major adverse events and deaths among the patients with necrotizing pancreatitis are not in favor of a group where it's performed open surgery in comparison to step-up endoscopic approach. So it means first endoscopic drainage and then, if needed, direct endoscopic necrosectomy. The same results is from this JAMA publication where infecting necrotizing pancreatitis and endoscopic necrosectomy reduce pro-inflammatory response as well as clinical endpoints compared to surgical necrosectomy. It's very important to see this trend, but we still see a lot of patients here in Denmark treated different ways and probably not even following the latest guidelines or recommendations in these patients. This is recently published from Brunschot article in Lancet, multicenter randomized controlled trial. We're looking for the endpoints of major complications or death within 6 months in comparison of step-up surgical versus endoscopic step-up approach. There were no differences in these primary endpoints, but the rate of fistulas and length of hospital stay were lower in endoscopic group, thus favorizing this approach. There is other very hotly discussed issue is what is better, metal stents or plastic stents. There is a number of studies, even some meta-analysis showing there is a better outcomes with metal stents, with wall of necrosis and with less adverse events. However, there are also other studies showing that there is no superiority of metal stents over plastic stents in treatment of wall of necrosis. Because this will be covered by another lecture, I would just provide the bottom line of this, that we should probably follow and mostly apply Atlanta classification, where we diversify our patients and where we differentiate our patients for a particular procedure, either plastic or metal stenting, and also eventual direct endoscopic necrosectomy. When we are talking about biliary drainage, the major flaw of ERCP or major drawback of ERCP are, of course, those patients who fail. The reason for failing ERCP might be either anatomical reasons, or it may be also simple inability to reach the papilla or cannulate papilla with missing experience and so on. In those cases, we can perform either EUS-assisted or EUS-guided ERCP or EUS-guided ductal drainage. We differentiate in between downstream, upstream anastomosis in depending where it's located, the drainage, if it's above or below obstruction. This slide shows different approaches, either transgastric through the left liver lobe, or transduodenal to the distal common bile duct, and there are also shown approaches from the stomach through the pancreatic duct, which I will mention a little bit later. Excuse me. All these approaches can apply and can also help a so-called rendezvous procedures, or provide both retrograde and antegrade approach if we are unable to cannulate. In Aarhus, we have developed algorithm where all our patients have fallen with the strictures in the bile ducts, and depending of accessibility or inaccessibility of papilla, we have performed ERCP rendezvous or ERCP bile duct drainage. And then we differentiate it either depending on anatomy and pathology. If patients getting distal bile duct drainage or transgastric drainage in form of EUS-guided hepaticogastrostomy. This, of course, prerequisite for this application of this algorithm was that patients are receiving the treatment at the same session as failed ERCP. ERCP was performed in every refed patient, so we tried again, and patient gave informed consent or gives informed consent before every ERCP if this fails to proceed with interventional EUS. We use, particularly, this was very frequent indication, also forward viewing echoendoscope, therapeutic endoscope from Olympus, which is, I do believe, has some advantages while performing EUS-guided colorectal-duodenostomy. I personally do not see any other advantages except this one and only indication. It's more precise, we're placing the window of opportunity is better, and even narrow bile duct can be addressed. Before the era of lumen opposing metal stent, there have been numerous publications of EUS-guided colorectal-duodenostomy. As you can see, mostly those were case reports, only few studies, more than 10 patients. Pretty good technical success, even clinical success rate, but also quite high complication rate of almost 20%. The things started to change with the introduction of lumen-opposing metal stents, and particularly when have been introduced more simplified or complex all-in-one devices, which allow us to use even technique so-called freestyle technique, avoiding with the guide wire exchange of balloons or cystotomes, and simply do it as simple as possible. I guess most of you are familiar with this device, which is electrocautery enhanced device with lumen-opposing metal stent, originally developed by X-Lumina, then acquired by Boston Scientific. It's Luer-locked on the therapeutic echo-endoscope channel and has a very special and unique delivery device system. Stepwise, you can very well and safely release this stent. Another very important tools. It's more questionable, but I still think that it's valuable. Are semi-covered stents, where one half is covered, the another half is uncovered. Probably you cannot appreciate it so much on that slide, which we are using for EUS-guided hepatogastrostomy, where a covered part helps us create and heal anastomosis in between stomach wall and liver capsule, and uncovered part. Thank you. An uncovered part simply doesn't occlude lateral branches. It needs to be said that many studies and many centers who has not availability of this stent, just using fully covered straight stents. We are also developing new stents. This is coming also with very new, unique introducer set next year on the market, specially designed for hepatogastrostomy. Numerous studies have shown that EUS-guided bile duct drainage may be very well a good alternative to percutaneous as well as surgical approach when ERCP fails, when we are unable to cannulate or reach papilla. And safety, feasibility, and effectiveness are very similar to that. We published also some initial data. This was a mix of the patients, not just only lumen opposing, but also other techniques. Prospective, looking at quite a good and quite high technical success as well as clinical success, with reasonable, acceptable adverse events in comparison to surgery and radiological approach. The other studies from the era before lumen-opposing metal stents shows the same suggestions, or showing same conclusions, that it might be a very good place of EUS-guided colodochoduodenostomy in treatment of in the cases of failed ERCP instead of surgical or radiological approach. Here I would like to highlight Ogura's paper from 2015 in published in Endoscopy, where there is favorized EUS-guided hepatogastrostomy over EUS-guided colodochoduodenostomy, suggesting that there is longer stent patency and fewer adverse events. This is not reproduced by other studies, and it's questionable if we can validate these results again. The other studies show more or less there is the same efficacy, and it's also consistent with our own study group. Reem Sharaya from Weill Cornell University published this meta-analysis of 9 studies of 483 patients comparing bile duct drainage, EUS-guided bile duct drainage with percutaneous biliary drainage. And it showed no difference in technical success. It was associated with better clinical success, fewer post-procedure adverse events, lower rates of reintervention, and was more cost-effective than PTBD. That's very favorable results for EUS-guided drainage. For this type of drainage here in Europe, we are using 6, 8, and 10 millimeters stents. These were some initial lumen-opposing stents data related to the colodochoduodenostomy, showing again high technical success over 98%, clinical success over almost 97%, and quite low complication rate or adverse events rate of 7%. We still need prospective and randomized data. Currently, there are two major studies ongoing, or one is really ongoing, organized by Anthony Teo from Hong Kong. We still need more comparison with PTCD surgery and ARCP, more data on stent patency, adverse events, quality of life, as well as cost effectiveness. Here in Denmark, we did some interim study of cost effectiveness, and it pays well off to use alumina-posing metal stents, but it may differ because the prices of the stent differs also from country to country. Couple of studies like Andrea Anderlonis and myself were suggesting that it may replace completely PTC in cases of failed ERCP or be at least complementary to the other procedures. The advantage of this procedure is that it's in the same session as ERCP, as failed ERCP. It's done in sedation. In my institution, it used to be on outpatient basis. It's very short. The mean procedure time with Ryzen expertise is about 4 minutes, and very good quality of life. There are no limitations by obesity and ascites, particularly when using forward-viewing therapeutic echoendoscope. There is no need for any drain care and no loss of bile. There are no reports of pancreatitis, which is also very, very significant finding. This is just for illustration. Significantly dilated bile duct punctured by hot Axios device, 6 millimeter times 8 millimeter. The threshold for me personally is about 8 millimeter dilated bile duct, but usually I would advocate 10 to 12 millimeters as a threshold for attempt to place this stent. There have been some concerns about the size of flanges, but actually I have never experienced any occlusion of the stent, even if duct has collapsed. So this is a real-time video that's not even widely edited. And for study purposes, it's performed cholangiography, but usually it's not necessary. We looked at our own data in the like a 5 years analysis from using alumina-posing metal stent, looking for technical success as well as clinical success defined as a sufficient fall of liver function test allowing to commence oncological treatment, and looked, of course, at the adverse events. As a summary, we simply succeeded in all 251 patients where this procedure was performed, and there was no technical failure, perhaps also mainly because we were using that forward-viewing echoendoscope, which gives slightly more maneuverability. Slightly more maneuverability. I would like to underline, and again, I'm saying it very often, that that this is not a replacement of ERCP, that's a complementary. 97.4% of these patients had an inaccessible papilla, so ERCP was technically not possible. The remaining 2.6% patients had accessible papilla but failed cannulation and had a vital indication because of cholangitis or sepsis. Another study from Florida shows similar rates of adverse events and treatment outcomes as ERCP. This is for the primary biliary decompression. This is a very small study. However, it's a randomized study, so it has, of course, its value. Another South Korean study, more significant, I would say, it's this comparison again for primary biliary decompression. There is no difference in technical and clinical success comparing ERCP with EUS and bile duct drainage, but there is a shorter length of hospital stay. Overall adverse events seems to be also lower, but significant is 6 months stent patency. It's much higher in EUS group, Reintervention rate is also significantly lower, and quality of life is significantly better for EUS-guided patients. And this is also consistent with our own results. If you look for another approach in terms of EUS-guided hepatic gastrostomy, Ogura reports very high technical as well as clinical success rate, but also quite a high adverse events rate of over 23%. This is the procedure where we visualize left envelope either in segment 2 or 3 during the puncture with O35 needle, injection of contrast to visualize bile ducts from, in this case, from segment 3. You can appreciate the stricture in the liver hilum and the introduction of semi-covered hepaticogastrostomy stent, and you will see immediately like a pneumobilia and functioning anastomosis. This is very good complementary approach also in other patients where we have multiple segments blocked by huge tumors, like this Bismuth 3 case, where we first needed to address ventral and dorsal segments, transpapillary, and then complement this with transgastric approach and thus achieve drainage of all segments. Even we can approach and treat patients with Bismuth 4 pathologies where this is not possible to perform ERCP due to duodenal stent. Simply first was performed hepatic gastrostomy, and there was traversed liver hilum, dilated and inserted another stent in a liver hilum. Currently we are working on a new technology which can, almost like in a form of tips, do a communication and fistula in between the left and right liver lobe. We have done already a few cases with this, both experimental as well as human cases. This is our own experience from Aarhus, where I was affiliated until recently. Very low adverse events, and also technical success was pretty high. Those which failed were simply where we not failed to not puncture, but mostly that there was not a possible to achieve clinically significant and sufficient drainage of bile ducts. As I mentioned, the comparison of Ogura and favorizing EUS-guided hepaticogastrostomy in contradiction is this systematic review and meta-analysis, which shows that they have actually equal efficacy and safety, and both are associated with very high and clinical success. The choice may be selected based on patient anatomy, where the stricture is located, how is their duodenum accessible or not, second portion of duodenum accessible, and so on, which is also, again, consistent with our own experience and results. We have done also more, less standard cases with major bile duct injuries, like here, missing complete extrahepatic bile ducts after right hemihepatectomy, impossible to perform drainage from the stomach because of flipped left liver lobe. So we needed to puncture from the duodenal bulb and address this junction of the left and right hepatic duct, where there is introduced PTC, but surgery or further percutaneous range were not sustainable. You can see that puncture and the distance from duodenum is pretty high. It's over 3 centimeters, so it's nothing for lumen-opposing stent. So we use semi-covered stent for create such a long anastomosis, which was removed after 6 days, only 6 days, creating this fistula, and replaced by fully covered silver-expanded metal stent. This patient is still alive, had other complications related to his colorectal surgery, but in terms of bile ducts, there are no complications. This is more than 3 years. It was actually in May 2015. Even pioneers like Rick Kozarek, or pioneers of ERCP like Rick Kozarek, see the place of EUS to complement ERCP in some failed cases. Typical and very good example is our new opportunities in cases of pancreatic stones, where we are unable to provide significant, there is a stone here, significant relief of pressure in the intrapancreatic duct. So we can perform either antegrade rendezvous procedure or antegrade stenting in form of EUS-guided pancreatic gastrostomy. I usually insert self-expanding metal stent, fully covered 6 mm in diameter, and then address like this with a pancreaticoscopy and perform electrohydraulic lithotripsy in the pancreatic duct with very good results on a clinic, with very good clinical results. I will not comment more on this. Maybe we can discuss afterwards. There are not any solid data, not any reproducible data, not any studies on this, and most of the reports regarding the pancreatic drainage, pancreatic duct drainages, transgastric are based on case reports or very small data. As for the gallbladder, the history goes not so long time ago, when the first was performed by Todd Baron in 2007 using 2 7 French double pigtail stents. And first lumina-posing metal stent was used in 2013 by Manuel Perez Miranda in Valladolid. This is, of course, in cases of acute cholecystitis, when we perform transgastric or transduodenal drainage of inflamed gallbladder. These are some images from our study published altogether with Markus Dollhopf, showing both EUS and CT images and endoscopic image. The most significant publications suggest that there is very high technical success rate as well as clinical success rate in EUS-guided gallbladder drainage, but there is substantially lower risk of overall as well as severe adverse events. Moreover, Irani also shows and points on shorter lengths of hospital stay, lower pain scores, and fewer repeated interventions, and fewer adverse events. This postulates the EUS-guided gallbladder drainage may potentially replace PTGBD as a treatment of choice in patients who are unfit for surgery. Again, we had these some of our mostly our cases used with very high technical and clinical success, with relatively limited but serious adverse events. And we also looked in a comparative study published this year in Surgical Endoscopy, where comparing transpapillary percutaneous and EUS-guided gallbladder drainage, and we see that it's effective and safe alternative with significantly lower procedural adverse events than transpapillary and percutaneous approach. This meta-analysis presented at DDW this year, based on already mentioned 3 major studies, including also Amy Tyberg's study from 2016, so shows favorable results in terms of better technical success, similar clinical success, less total adverse events, less severe adverse events, reduced hospital admissions, reduced reinterventions, and no difference in mortality, favorizing slightly EUS-guided gallbladder drainage. In Europe and in Denmark, we have this as a approved indication for lumina-posing metal stent. In Denmark, most of you know that patient is a significant part of decision-making process, so they very much appreciate the impact of this technology and this procedure on the quality of life, as well as short hospitalization. We went a little bit beyond. We are using this not only for patients who are unfit for surgery, but we are looking very closely at the candidates who may potentially change their mind, and when they previously opted out from a surgery, they will opt in later, or they become simply clinically better and become candidates for a surgery. For all these options, we favorizing lumina-posing metal stents. All these options are viable, but using plastic stents or straight cell-expanding metal stents bears higher risk of complication by leak. For these, we favorize 10 and 15 millimeter in diameter self-expand metal stents. There are different locations where you can place your anastomosis. It's very important to understand all the nuances, and particularly in terms of complications, once you commence the puncture, and you puncture even with a needle gallbladder, the procedure it's imperative that it ends with a technical success, otherwise it results with a bile leak, peritonitis, and might have severe consequences. There are also other things which we have to evaluate while performing EUS-guided gallbladder drainage, as a content, size of gallbladder, size of stones. Be very careful, who is suitable, who is a good candidate, is it ascites or any other free fluid, and what is also anatomy. I think that we are short of time, but these are just illustrations how procedure is done through the duodenum and through the stomach. Again, there are also some other nuances which needs to be known. It should be created as a tension-free anastomosis. You should be aware about that approximation of the gallbladder should also take in account subsequent exsufflation of stomach, shrinkage of gallbladder in the process of healing. Very often mistake I can see while doing this procedure all around the world is that when you pass the muscularis, so a lot of people ends up first in the submucosal layer, and they are not completely through the mucosal layer, which is very floppy, which is very, very saggy. As I said, we are using this procedure also for potential surgical candidates, but we still need to evaluate and clarify what is good timing for definitive surgery and cholecystectomy, and what is the optimal duration of stenting. There is not even unity for surgeons even after percutaneous drainage worldwide. So this is another challenge we have, and also there are other questions which needs to be answered, when to remove stent before the operation and so on. For those who are not surgical candidates, we have applied also a new algorithm. If they keep the stent, if they keep the cholecystoduodenostomy or cholecystogastrostomy, we perform in 6 weeks. We perform direct perioral cholecystoscopy, and if there are remaining stones, we perform electrohydraulic lithotripsy to achieve complete clearance from gallbladder. We have submitted publication of 2 cases of ileus caused by remaining stones, which simply pushed and facilitated also migration of the stent. The similar approach is also applied in Southeast Asia nowadays. There is more proactive, not a passive approach, and we are trying to achieve complete clearance. There are limited data on post-surgical or surgical treatment of these patients. However, we published also this year conclusions that if patients' underlying medical conditions improves, prior EUS-guided gallbladder drainage shouldn't preclude eventual interval cholecystectomy as a part of the standard care. So EUS-guided gallbladder drainage is complementary or even alternative approach to other means of gallbladder drainage in cases of acute cholecystitis before interval cholecystectomy. Despite we have limited data, there is no increased risk of adverse events based on so far published data. And every patient needs to be very carefully evaluated based on anatomy, local findings, and it should be very, very carefully individualized. All these interventions I have mentioned are redefining our GI surgical and endoscopical approaches, very often reinventing completely the field, how we look, how we approach, but also how we treat these patients. They are highly beneficial in cases with a surgically altered anatomy, where we otherwise were doomed to use mostly percutaneous approach. Some of these are completely new techniques. All these we are trying to perform with a very close cooperation of multiple specialties, so really close and real multidisciplinary cooperation. And we still think that we provide less invasive procedures, even in comparison to laparoscopy or other procedures, and potentially these procedures may replace other minimally invasive approaches. Thank you very much.